So, good afternoon. We'll be talking about myelopooesis, structure and function of myeloid series, an inherited disorder of the myeloid series. My last lecture with you, what did we talk about? Hematopoiesis and erythropoiesis. And I said we are going to be picking them one after the other. So this afternoon, we'll be talking about myelopooesis. At another time, we'll be talking about thrombopoiesis. At another time, we'll be talking about lymphopoiesis. But for today, I'll be starting with this diagram again, just to remind you of the pluripotential stem cell will give rise to myeloid committed stem cell, just to remind you, and lymphoid committed stem cell. The myeloid committed stem cells will give rise to the megakaryoblast and then eventually to platelets. Also give rise to proerythroblast, which is a precursor cells, and eventually to red cell, and then to give rise to myeloblasts, which we are going to be talking about today, and then the various type of myelocytes. Myeloblast is a immature form of myelocytes. Is the precursor form of, so we say blast, meaning that it's immature. Myelocyte is the mature. So we have various types, and you are familiar with them already. What are the various myelocytes that will arise from this development? Neutrophils, eosinophils, basophils, monocytes, and okay. So these are the various myelocytes. But if you talk about lymphoblasts, then you'll be talking about lymphocytes, which will give rise to B or T or natural killer cells. Okay, so this is the development. So you will have all the various stages for each of them. For basophil development from the myeloblast stage, neutrophil from the myeloblast state, eosinophil from the myeloblast state, and then the monocytes from the myeloblast state. Okay, so this is another diagram showing you the hematopoiesis and all their, the progenitor cells and the precursor cells and the final cells, the eosinophil, basophil, erythrocytes, monocytes, neutrophils, and then the lymphoid cell, which we are not talking about today. Okay, so this is another diagram. I want you to appreciate and understand. So you can see from the development from the bone marrow myeloblasts. We are going to talk about, we have discussed common myeloid cells, so it's going to give rise to the precursor cells. When we are talking about myeloid series, so we are picking on this. Myeloblast is the most immature form, followed by the promyelocytes, and followed by myelocytes, followed by metamyelocytes, followed by the band, and then this is for neutrophil. You can also have for eosinophil, like myeloblast, eosinophil, myeloblast, eosinophil, promyelocyte, eosinophil, myelocyte, eosinophil, metamyelocyte, eosinophil band, and then the eosinophil itself. You can have for basophil, and you can have for monocytes. And look at for neutrophil, the white cell lifespan, total white lifespan from the myeloblast to development of mature neutrophil takes like 3 weeks. But once it enters into the peripheral blood, The lifespan is in hours, 7 to 10 hours. So what happens after 11 hours in the peripheral blood? Who knows what happens to the neutrophil after production and 11 hours, 12 hours, 13 hours? What happens to the neutrophil? What happens? The phagocytosis is, you know, is a phagocyte. It's also phagocytosed by what? By the by the by the spleen and the liver. So after it has outlived its lifespan, the liver mops them up and destroys them. So then further leading to further production of more of the neutrophils. So what's the lifespan of red cell? Everybody should know that 120 days. So the lifespan of neutrophil is what? The peripheral blood. 7 to 10 hours. 7 to 10 hours, okay? So this is the developmental stages again. They're explaining what happens. You can appreciate it that as it matures, the nucleocytoplasmic ratio reduces. Is it reducing or increasing? It's reducing. The nucleus is getting smaller and the cytoplasm is getting bigger. Okay? So you can see as it matures, how many days that say it's going to mature in the bone marrow? Sorry? 13 to 20 days. So as the days goes by, there is a reduction in the overall size of the cell. You can see that this cell is bigger than this eventually, and the nucleus becomes more segmented, more fragmented. How many lobes do we have for neutrophil? 3 lobes. Okay, you can see that it's not lobulated. So as it matures, the nucleus shrinks and becomes lobulated. And so these are the various stages: myeloblasts, promyelocytes. So if you do a bone marrow, these are what we count. These are what we count and use that to determine diagnosis. So if you have leukemia, acute leukemia, there is maturation arrest. So there is no maturation from myeloblasts to this because of mutation, one mutation or the other. So you now have plenty, very plenty of the immature myeloblasts in the marrow, and as it continues, it spills into the peripheral blood. You are not expected to find immature cells in the peripheral blood because the maturation must have been completed in the marrow before it moves into the peripheral blood. So if I draw your blood and I start seeing blasts, then there is a problem. Then the person has acute leukemia. So so it's very easy for us to diagnose acute leukemia from just making a blood film. So if you see a blast, so depending on the type of blast, we are trying to identify blasts. Is it the myeloid blast? Is it the lymphoid blast? We are seeing the peripheral blood. So if you see myeloid blast, then you can make a diagnosis of acute myeloid leukemia. If you see a lymphoid blast in the peripheral blood, we make a diagnosis of acute lymphoblastic or myeloblastic. You can use myeloblastic if you like. You can use myeloid. You can use acute lymphoblastic or acute lymphoid. So the next investigation to be done, if you see blast in the peripheral blood, is what? What do you now do? What do you do? If I draw your blood from a vein and I see blast, myeloid blast, what is the, and I'm suspecting acute myeloblastic leukemia, what is the next investigation to be done? What? I have to do a bone marrow aspiration. So I will do a bone marrow aspiration and then make a smear again and then look at, so in some cases we will estimate the percentage of blast. Ideally, you and I, if you don't have leukemia, the blast percentage should not be more than 5%. 5% of the total nucleated cells. All the nucleated, this is the nucleus. It should not be more than 5%. But with acute leukemia, as high as 90%, 80%, 70%. So you can say, okay, you can confirm a diagnosis of acute myeloblastic leukemia. Okay, so these are myeloid series classified on the basis of nucleus and the granules, polymorphonuclear phagocytes and granulocytes. We are familiar with them. The neutrophils, they have granules, and then eosinophils and basophils, they are called granulocytes because of the granular content, the granules they contain. And then the mononuclear phagocytes, they are just one nucleus, not three lobulated, mononuclear, just one nucleus. So they are monocytes. Monocytes can also be called macrophage if it's in the blood, okay, or in the tissue. Macrophage in the tissue, monocyte in the blood. So it's, as part of what you should know in this lecture, is for you to be able to identify these cells. You should be able to identify, you should be able to draw eosinophil, you should be able to draw basophil, you should be able to draw and identify neutrophil. So that is a neutrophil, and then eosinophil, okay. So this is how a neutrophil looks. It has three lobes, and then it is granular. You can see the granules. You should be able to draw this in it's part of your exam, the practical. It can be part of the essay. You can be asked to draw a neutrophil. You can be asked to draw eosinophil. So if you want to draw eosinophil, what crayon will you need? What will you need? So, eosinophil. You will need what? Or pink. So usually pinkish. You need a pinkish because you put a dot, pinkish dot, to identify eosinophil. So this is neutrophil. This is how it looks under the microscope. You can see the various lobes of the nucleus. The lobes should be between, how many lobes? Between 3 to 5 lobes. 3 to 5 lobes. So some could be hypolobulated and some could be hyperlobulated. Okay? Some could be hypolobulated for one reason or the other. We're going to talk about it. And some could be hyperlobulated. So this is how neutrophils, this is how they look. And you can see that this lobe, this cell's lobe is not completely, it's not separated. You know, it's like a horseshoe shape, but you can see identify. And this one, but this one is ragged. This one, so they will have abnormalities, which is what we called the abnormal neutrophils or inherited type of, it could be acquired, it could be inherited, that could affect the shape, the size, the content, and then the overall size of the neutrophil. So this is an eosinophil. If you ask, so usually bilobed, and then it has a pinkish Granules is as pinkish. What color? What's the color of granule for neutrophil? Neutrophilic granules. What color? It should be purple. It should be purple. But eosinophil should be pinkish. So this is eosinophil. This is how it looks under the microscope. It is highly granulated. You can see the granules. What is eosinophil? What is the function of eosinophil in infection? What kind of infection does it attack? And phagocytosis. Sorry. What kind of infection? Sorry. What? Worms. Parasitic infection. Parasitic infections. So if you have worms, if you do your full blood count, worm infestation, your eosinophil will be high. What other condition will cause eosinophil to be high? Allergy. So if you have asthma, allergic rhinitis, if you have exacerbation of your allergy, if you do a full blood count, some people have allergic dermatitis, your eosinophil will be high because the body will mobilize all the available eosinophils from everywhere and then try to prevent or reduce the effect of the allergy. This is a basophil. Usually it's not bluish actually, but this picture is not capturing it well. The granules is also bilobed like the eosinophil. Eosinophil is bilobed with pinkish granules. Basophil is usually bilobed with also bluish granules. Okay, bluish granules. So this is how it looks, but the nucleus are not too conspicuous. If you make a smear, I've told you how to make a smear. How do we make a smear? Remind me, I mentioned it last time. How do you make a smear? You are not in class and you didn't watch the video. Okay, so how do you make a smear?
You look at the source, the central like thing.
Sit up and speak up.
You look for the central like external for any.
You make a smear on the slide. A drop of blood on the slide. Use another slide, a spreader slide, and then draw the blood. And then it's going to appear. You are like thinning it out. It has a tail and a body. So you allow it to dry, and you stain. What stains will you use in hematology? We use Leishman stain, most likely, mostly Leishman, or we use May Grunwald. We also use Giemsa stain. We use Giemsa stain. Okay. So when you stain, you now allow it to dry, and then put it under the microscope. This is what you're going to see. It's very rare to see eosinophil in the peripheral blood. Very, very rare. Because the amount of eosinophil in the peripheral blood is like 0.02% of the total myeloid cells. 0.02. Neutrophil is the commonest. It should be like 40 to 50%, maybe followed by lymphocytes, then followed by eosinophil, the monocyte, and basophil. So you may not see, except you have condition that will trigger basophilia. That's what we call it. Basophilia. Okay. So, and this is monocytes, and you have from monoblast to promonocytes to monocytes. Okay, that's the development, and the nucleocytoplasmic ratio will decrease if you wash from here 7:1 to 3:1, but the matured monocyte, it has dropped to 4:1 to 2:1. Okay, and these are all the other changes that occur with monocytes from monoblast stage. to monocyte stage. Okay, and this is how a monocyte looks under the is bigger than neutrophil, and the nucleus is not lobulated like that of neutrophil, and then is indented. We call it indentation of the nucleus. The nucleus is indented and is bigger than, then it's also granular. It's also granular. Okay, so these are the various. I hope you'll be able to identify them if you are given this in your first in course, to identify how they look. What about macrophage? Where is it coming from? From from monocytes. Tissue form of monocyte is a macrophage, but blood is monocytes. Okay. So just like we did about regulation of hemopoiesis, this also there is regulation of erythropoiesis, and these are all the regulators involved in the you can see the from Janus kinase, and then followed by thrombopoietin. The abbreviation, you can just take your time to read the diagram. The erythropoietin is also there. Then there is interleukin, the stem cell factor, GCSF. I mentioned GCSF the last time. Then these are all what stimulates when there is, for example, an infection, bacterial infection. The regulators involved in production of neutrophil will stimulate production of neutrophils in order to invade the invading bacteria. You know, you have a bacteria invading your bloodstream. The body will mobilize more production of neutrophils to attack. So they are like the soldiers of the body, to attack and begin to phagocytose all the bacteria, and then they will now release their granular content, which are toxic, to destroy. They destroy the bacteria and kill the bacteria. It's whenever the bacterial infection is overwhelming. When the bacterial infection is overwhelming, for your body neutrophil to conquer, then you are down with fever, you are down with infection. So what do you do at that point? What do? You just wash the bacteria to kill you. What do? You use antibiotics to kill the bacteria. So if you don't use antibiotics to kill the bacteria will kill you. And that is happening in a diagnosis called what? Septicemia. When the quantity of the various gram-positive, gram-negative bacteria overwhelms the body defense mechanism, which is your neutrophil, then the person comes down with severe sepsis, and then you begin to try various antibiotics. Does it make sense to you? So these are the characteristics of all the granulocytes and the agranulocytes, involving the number, percentage in blood circulation. You can see neutrophil is 60 to 70% actually. Eosinophil is 1 to 4%. Basophil is 0.2 to 1%. Monocyte is 2 to maybe 3%. And macrophage is in the tissue, is none. Okay, so range their peripheral blood, then their lifespan, their granules, and their granular content. Like I've said, they have toxic content. in their granules. So the initial thing that happens is that they try to encircle the bacteria and then tuck the bacteria inside the cytoplasm. And then once the bacteria gets into the cytoplasm, the granular contents are released to kill the bacteria, and then they dry. And don't forget, the lifespan of neutrophil is in hours, so just within 10 hours the spleen, they move to the spleen. Spleen will mop the neutrophil and the engulfed bacteria together and then destroys it. Okay, so that's the sequence and that's what happens. Okay, so you should be able to identify. So somebody should come forward and identify these cells. Who wants to volunteer? And make it fast because of time. Volunteer. Make it snappy. You are looking at this. Nobody wants to volunteer. I will call. Okay, you want to volunteer? Okay, volunteer. Who wants to volunteer? Are you volunteering? So just quickly point. You are spying. Just quickly because of time. Is what? Yeah, see nothing. No, you missed it. Look at it again. I know, but no, I can tell you. Look at the color of the granules. The color of the granules. No, it's not basophil. It's neutrophil. Actually, it's neutrophil. It's neutrophil. Okay, move on to the next one. Why is it monocytes? Indented nucleus is mononuclear, is granular, and is large. So those are the characteristics. Move to the next one. This one is a lymphocyte. We have not discussed it. It's a lymphocyte. Lymphocyte is smaller than monocyte, but it should be agranular. It should be, and it's also mononuclear. It's a mononuclear. Okay. That is a good neutrophil. This is called a band neutrophil. Actually, band. Why is it a band neutrophil? It's immature form. So if you have sepsis, you will see a lot of band neutrophil in your blood smear, because the body is just continually producing neutrophils, so they are not properly matured before they are pushed into the peripheral. So this is a band neutrophil. Okay, so what about this? This is a basophil. What about this? Eosinophil. Why is that eosinophil? It's bilobed,
And it has
pinkish granules. Good. Yeah.
monocytes. What you call monocytes? What is that granules?
You should have granules. Yes. Granules is granular. It's only okay. You know, it's not. There is no hard and fast rule about it. You will see some lymphocytes with granules. You will see some without granules. So it's not sacrosanct, but they also have content in their cytoplasms that are granules that may not be obvious, and then they are used to destroy. But at times it is grouped as a granular. At times it can be grouped as granular. Okay. Yes. No, if you're in the exam, you just be asked to draw. They will be giving crayons like you use in primary school, different colors, and then there is a steeplechase. So you get to your spots, you draw and color. So we want to see whether you are putting 3 lobes for neutrophil and then purplish granules for neutrophils. We want to check whether you are putting 2 lobes for eosinophil with pinkish. So that's what it is expected from you. in exam. So you should be able to identify. You can see this, but at times because of maturation arrest, some of these developments may not be as I've described to you. Like the band, it's still neutrophil, but the neutrophils, the nucleus is not completely lobulated. Okay, it's like horseshoe. So you will not see that and say, okay, it is not a neutrophil. So you have to consider the color of the granules, you have to consider the size. So you cannot use just the nucleus alone to determine. Okay, so you can see, you can use this at your convenience to identify these labeled cells. Okay, so these are the functions. We have mentioned some of the functions of the granulocytes. I've described eosinophils. The basophil is increased in chickenpox and sinusitis, then diabetes. You can have basophilia. Secrete histamine. Histamine is the granular content. Histamine, the secretes flow into the blood, and then there is a secrete heparin too, which is also part of the granular content. The neutrophils, these are the characteristics of the neutrophil, the lifespan, the amount in the blood, and then the function. Okay, so you could have conditions that will cause neutrophilia. I've described sepsis. Then you could have neutropenia. Neutropenia is when the neutrophil count is lower than, and these are the various conditions that will cause neutrophilia and then neutropenia. Neutropenia in aplastic anemia, in metastatic cancer, in myelodysplastic syndrome, if chemotherapy can destroy the marrow and then to affect production of all the cell line, including the neutrophil, we have neutropenia. In aplastic anemia, the marrow is replaced, hemopoietic cells are replaced with fat cells, and so there is no production. So you have neutropenia. So you should know the conditions that will cause neutrophilia. So the importance of this is that the neutrophil count should be between, percentage should be between 60 to 70%. And then you did a full blood count, neutrophil count is 95%. What will come to mind? What will come to mind? Sepsis is the first thing that will come to mind. So you want to do a blood culture and see whether you want to identify the bacteria responsible for the sepsis, and then do antibiotic spray to test, and then that will give. But you can also empirically start on broad spectrum antibiotics while you are waiting for your blood culture results. So when the blood culture result comes back and then the antibiotics is not sensitive to the bacteria, then you stop it and change to the sensitive. So with full blood count, okay, another thing that happens in sepsis is the neutrophils, the granules become toxic. You see toxic granules. They are very prominent because they've been used and they are overused in the process of releasing their granular content. So when you make a smear, you see very toxic, you see the picture, and then you can, so from hematologists can also confirm sepsis apart from microbiologists. Microbiologists will collect the blood, do a blood culture, identify the bacteria causing the sepsis, then test the various antibiotics on those in the lab, on those bacteria, then recommend the sensitive antibiotics to the physician. But hematologists who can do a blood smear, before the blood smear, we do a full blood count and see neutrophil count 95%. Then you do a blood film and then you see toxic granules. You can also suspect sepsis. Okay? So how do you do absolute neutrophil count? is important. You go do your absolute neutrophil count is the neutrophil percentage over total white blood cell. Okay, if your neutrophil, I've done a full blood count and your neutrophil percentage is 20%, okay, and then you multiply that by the total white blood cell. Okay, so the total white blood cell is 10,000, so it will be 20 over 100 times 10,000. That's your ANC. You can also do absolute eosinophil count using that same formula. Is the percentage of eosinophil times total white blood cell. Okay, you expect absolute eosinophil count to be high when you have allergic condition or parasitic infection. So you expect absolute neutrophil count to be low. Neutrophil this time, if you have any condition that will cause neutropenia, like aplastic anemia, chemotherapy, and so on and so forth that I've listed, and you can grade it, because if your neutrophil count ANC is less than 500, for example, that's grade 4, then your body is at the mercy of all the various bacterial infection. Your body cannot mount any resistance. So what we do is to give them prophylactic antibiotic. You don't want to wait until there is an infection, okay, to break them down. So prophylactically, we'll give them antibiotics. So you can use this to grade. So grade 1 is when your ANC is between this. So ordinarily, if I do your full blood count, your absolute neutrophil count should be more than 1,500 or at least 2,000. Okay, so if it's between 1,500 to 2,000, that's grade 1. Okay, if it's greater than 1,000 but less than 1,500, is grade 2, and so on and so forth. So that's about ANC. Okay, so I will soon round up because we didn't start early, but you can just go through it. It's the same thing for eosinophil. We're talking about functions of eosinophil. Eosinophilia, these are all the causes of eosinophilia: allergic reaction like asthma, hay fever, and then fever, drug sensitivity, parasitic infection, hypersensitivity reaction, and all will cause skin dermatitis, will cause eosinophilia. And eosinopenia, when the value is lower than normal, is also expected in those clinical conditions. Okay, and similarly basophilia and basopenia. Basopenia is not too common, but we see basophilia even in allergic reaction because of the histamine content, the heparin content it has. Then the chronic myeloid leukemia, in which there is uncontrolled production of all the myeloid series. What are these myeloid series I'm talking about, if you remember? Myeloblasts, promyelocytes, myelocytes, metamyelocytes, band forms. So you have a condition in which there is a mutation called Philadelphia chromosome mutation, and there is an uncontrolled production of all the myeloid series. That condition is known as chronic myeloid leukemia. What's the normal white blood cell count? 4 to 11,000. But in chronic myeloid leukemia, the total white blood cell count can be as high as 150,000, 200,000, 300,000, 400,000, 500,000. You do a full blood count and your white blood cell is 500,000. Whereas it should not be more than 11,000. But these white blood cells, as high as they are, they have abnormal functions because they are not properly produced. Okay, because they are not properly produced, they are also predisposed to various infections despite this high count of white blood cell count. Okay, so in such a case there could be basophilia because it affects all the myeloid series, including the eosinophils, including the basophils, including the neutrophils. Okay, all the myeloid series, and then you start seeing promyelocytes myelocytes on the peripheral field, which you should not see. That should be marrow, but because they are improperly produced, they are pushed prematurely to the peripheral, and then Hodgkin disease, oral contraceptive pill can cause. So this is for monocyte, monocytosis, and monocytopenia. Monocytosis and monocytopenia. Okay. So these are the, I've described the phagocytosis effect, the three types of phagocytic cells. Neutrophils are the first to arrive, followed by monocytes. There are organ-specific phagocytes in the liver, the spleen. So this is what is how the cells attack the various invading organisms. So neutrophil, because of the quantity, and then ability to attack, engulf, and then releases its toxic content, the granules. Okay, and this is how it happens through diapedesis. It's called diapedesis. Moves gradually like amoeba and then migrates towards the invading organism, and when it gets there, engulfs. Don't forget, the body would have stimulated. Once you have infection, body will, through the granulocyte colony stimulating factor, through your interleukin 3 and 6, the body would have noticed an infection, then causes the release of these regulators and stimulates production of neutrophils. And once you have neutrophilia, the neutrophils through diapedesis, and meaning through amoebic movement, will move towards the invading organism, phagocytose, and digest the organism. So if it is capable of digesting it. So these are the primary granules. These are the contents of the primary granules. Primary granules are those in the marrow, but as they mature, they become secondary granules. So myeloperoxidase, elastase, then these are the names of the secondary granules. You also have them in matured neutrophils, primary granules, secondary granules, and tertiary granules. So you have myeloperoxidase, esterases, acid phosphatase, lysozyme, collagenesis. All these are been identified. They are enzymes that are used to break the cell wall and the membrane of the bacteria. They use the enzymes to break and digest the cell wall. So this is the phagocytosis I was trying to describe. Okay, so these are the various inherited disorder of neutrophils which we are trying to. So there is this Pegler-Hooch disease. Pegler-Hooch, the horse-shaped neutrophil, the nucleus is horse-shaped nucleus, like the band neutrophil. So this is what is called a Pegler-Hooch disease. Pegler-Hooch disease. You can see the neutrophils with a thin band, a band linking the two nucleus together. So this is what is called a Pegler-Hooch disease. Okay, so these are the various abnormal neutrophil morphology. You go have a hypersegmented. If you have more than 3 lobes, you have 5 lobes, more than 5 lobes rather, more than 5 lobes, 6 lobes, 7 lobes. It is seen in megaloblastic anemia. you see hypersegmentation of the nucleus. Okay, so this has how many lobes? 1, 2, 3, 4, 5, 6, 7, 8, 9. 9 lobes of the nucleus. Okay, so this is hypersegment. So these are the various abnormal neutrophils, and this is toxic granules, toxic granulation. You can see the granules, they are very prominent, and they are also seen in infection, in sepsis. You see toxic granules. I've said that. You see hypersegmented neutrophil. Which condition? Megaloblastic anemia. You see toxic granules under which condition? Sepsis. So I think, so these are the various forms of inherited. Because of time, I have another meeting now, and I have to be there. So I hope I've been able to deliver the lecture. Thank you for listening.